afternoon, everyone, and welcome to the Making Equity, the Bedrock of Value-Based Care and Payment webinar. Before we begin with today's content, we will go through a few short WebEx housekeeping slides. Firstly, just a reminder that this webinar is being recorded. There are two main ways that everyone can connect to audio, specifically using your computer audio or the WebEx Call Me feature to receive an automated call from WebEx. There is also live captioning, which is available for this event. To view or hide captions, click the Close Captioning button on the lower left hand of your screen. Lastly, you will be able to use the chat feature to let us know if you're having any technical problems during the webinar, as well as to submit questions and comments anytime during the presentation. Our moderators will be gathering those questions for us to discuss throughout the webinar, as well as during a designated Q&A section during this webinar towards the end. And before we begin, I will go ahead and bring down Anne so she can kick off our webinar.
Thank you, Miriam. Welcome, everyone, to this webinar today on Making Equity the Bedrock of Value-Based Care and Payment. If the whole point of value-based care is to get to the triple aim plus, better patient experience, better care, lower cost, joy in practice, and health equity, we can't get there without addressing the root causes of the dynamics in these areas. At Apt Associates, we wanted to discuss social determinants of health and how value-based payment and care models cannot be successful without tending to these factors of where we are born and where we live, learn, work, play, pray, and age. So today we have an excellent panel, which I'll introduce in a moment, and we're going to explore some questions with each other, mainly around what is the role of social determinants of health in optimal value-based payment and care models, and what's keeping us from doing more with social determinants of health in these models? What more can we do? We're very excited for this panel, each of whom brings a unique perspective to these questions. We can go to the next slide. So first, I'm introducing Andy Martinez Patterson. She is the CEO for the Alameda Health Consortium and Community Health Center Network. AHC is a health policy and advocacy consortium, and CHCN is a nonprofit Medi-Cal managed care organization providing business and administrative support for community health centers, the safety net in primary care. The member community health centers are headquartered in Alameda County, California, with services provided to surrounding counties. Prior to serving as the CEO at AHC/CHCN, Andy spent nearly 15 years at the Primary Care Association in California, which is where I first met her. Her last role was as the Senior Vice President of Strategy, Integration, and System Impact, where she worked for 10 years on building an alternative payment methodology for FQHCs in California. Andy has a master's in public policy from the University of Minnesota, Hubert Humphrey School of Public Affairs, and a bachelor's of arts in political science from the University of Illinois at Chicago. Andy, would you like to say a few words?
Yeah, just to say thank you so much for having me. It's one of my favorite conversations. I would say equity is my why, and the mechanism to get there has been value-based payment. So I'm really excited, and I'm personally excited because I know all of the panelists from various iterations of my life. So this will be a really fun conversation. Thank you.
Indeed. Thank you, Andy. Hopefully this will be a good conversation amongst old friends. So our next friend is Lynn Barr from Caravan Health. Lynn Barr is a leader in the movement to transform and improve our nation's healthcare systems for the underserved. Following a 30-year career developing innovative drug, device, and IT systems in 4 startups, she earned her MPH to pursue delivery system reform for the safety net, which was her primary source of healthcare as a child. When working at a rural hospital as a chief information officer, Lynn organized a national rural accountable care consortium to overcome barriers for rural health systems so that they could benefit from innovative and advanced payment models. In 2014, she founded Caravan Health to provide turnkey services to providers interested in population health programs in practice transformation networks, and Medicare and commercial accountable care organizations, comprehensive primary care plus, and other payment models. As CEO of Caravan Health, Lynn led the development and execution of nationwide programs that bring better care to patients and help safety net providers achieve financial success. Today, Caravan Health, which is now Signify Health, which is now bought by CVS, right, Lynn? Supports more than 20,000 primary care providers and 250 rural and safety net hospitals, making the transformation to value-based payment models and improving care for more than 700,000 Medicare beneficiaries. Her efforts have saved Medicare more than $500 million to date and earned her an appointment as one of the 16 bipartisan commissioners that advises Congress on Medicare payment policies, also known as MedPAC, with a focus on the safety net and advanced payment models. We are lucky to have you in that seat, Lynn. Would you like to say a word?
Oh, thank you, Anne. And I'm really excited to be here today and to talk about my passion in value-based care and the safety net and bringing all of this together. It has been an incredible journey in the last 10 years since the Affordable Care Act, as we've really seen huge transformation in the healthcare system, but we have so far to go. I do just want to make one comment that I am a commissioner on MedPAC, but I do not speak for the Medicare Payment Advisory Commission. Thank you.
Thank you, Lynn. And our third and final panelist is Dr. Sethi Hayashi. Dr. Hayashi is the lead medical director for government programs at CareFirst Blue Cross Blue Shield, which serves 3.5 million individuals and groups in the Maryland, Washington, D.C. metro area. He's also serving as interim chief medical officer for Blue Cross Blue Shield's D.C. Medicaid plan. Dr. Hayashi is board-certified family physician and is an experienced leader in primary care, quality improvement, and health policy at the local and national levels. Prior to CareFirst, he spearheaded health services integration and transformation at 2 area community health centers, Mary Center and Unity Healthcare, both in D.C. Hayashi's national health policy experience comes from his role as chief medical officer for the Federal Health Center program at the Health Resources and Services Administration. He started his career at Georgetown University and at George Washington University, teaching public health and conducting health policy research. Dr. Hayashi has received a number of awards and achievements, including the Samuel U. Rogers MD Achievement Award from the National Association of Community Health Centers, fondly known as NAC. Dr. Hayashi graduated with honors in studio art from Vassar College. He received his MD with Alpha Omega Alpha distinction from the Albert Einstein College of Medicine, and he completed his family residency training at the University of California, San Francisco. His MPH is from Harvard, and he was also a fellow with the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. And I think Dr. Hayashi, we first met in a meeting talking about how to improve access to family planning services and community health centers back when you were with HRSA. So welcome, and I'd like to invite you to say a few words.
Thank you so much, Anne. And I'm so excited to be part of this panel. My goal in life has really been to, just be helpful in whatever capacity I can. And although, I've had a variety of different roles and responsibilities over my career, I think the one common thread has been being a frontline care provider, as a physician, as a primary care doctor. And I think that experience is what sort of informs me on all the academic research policy, and now at the health insurance side, how do we, really make the best, provide the best care, the best services so that, people can become better. So I'm so excited for this conversation. Thank you.
Thank you. And so before we dive into the more wonky technocratic conversation, I just want to invite each one of you to share a little bit about your personal connection to this work. Tell us, why are you personally dedicated to advancing social determinants of health in value-based care, and how did you enter this journey? And let's start with Dr. Hayashi, since he's still on stage, and then we can invite the other panelists on as well.
Okay, thank you. I'll try to make this really quick. I've always been sort of a holistic thinker, and I think that's why I became a family doctor. And I actually originally wanted to be an orthopedic surgeon coming out of college and coming into medical school. But I found all areas of medicine interesting, and so I wanted to care for the whole person in the family. But my first major fork in the road was when I met Dr. Jack Geiger. And I don't know if you know Jack Geiger, the late Jack Geiger. During my first year of medical school, I met him. And Dr. Geiger founded the first 2 community health centers in the country. And he's actually famous for giving prescriptions for food for patients, using government funds to pay for it. When he was questioned by government officials about the practice of prescribing food, he said something like, the last time I checked, the treatment for malnutrition was food. And during medical school, he became my mentor, and he really showed me how a physician could be an advocate, not only for individual patients, but for the entire community. And he taught me about community health centers and what community-oriented primary care could look like. And interestingly, he said if I wanted to learn about community-oriented primary care, I should actually leave the country. And he told me to go to El Salvador. And so I did. I took a year off from medical school and went to a rural village in El Salvador. And there I helped, run a clinic. But we built bridges and we built, kindergartens and incorporated mental health, oral health, nutrition education into the kindergartens. And we did this by requiring parents to help with the kindergarten and rotations in exchange for free education and 2 meals a day for their kids. So the parents actually learned with the kids on health, education, literacy, oral health, mental health. And little did I know that 20 years after that experience, I'd be working at Mary Center, a community health center in Washington D.C. in Maryland, where we're co-located with a public charter school that uses that same 2-generation approach to family literacy, where parents and kids attend school together, and really incorporating all the social determinants of health, and making sure that everybody gets what they need. But so why now in health insurance? And just 30 seconds on this. Earlier this year, I was invited to a meeting on this exact topic of social determinants of health and value-based care, where I was in attendance with a number of chief medical officers from some of the major insurance companies. And I was complaining to them about how our clinic, our community health center, needs additional resources, to pay for the social determinant services. And especially since a lot of the cost savings actually goes towards the health plans. And so, one thing led to another. I had follow-up meetings and whatnot. And when I was talking with the chief medical officer of Care First, he actually said that they're working on it and that, they want to do more around social determinants, and if I would consider joining them to help out. So here I am. And that's my journey. And there's lots of, twists and turns in between, but here I am.
That's an amazing story. First of all, I didn't know that you knew Dr. Jack Geiger personally. That's impressive in and of itself. But I love this idea that complaining can lead to you having a seat at the table now on the health plan side, because I think that's really important, as well as your perspective that you bring as a former Fed. Someone who has been working in the health center program and understands it at that deeper level. So thank you for sharing your story. And since we're in the health center world still, I'll turn it to Andy to go next.
Thank you.
What's your
I love that Jack. I had no idea Jack Geiger's not only him, he was your mentor. That is an impressive undertaking. Well, I can say that you all are my friends, so I feel pretty proud about that one too. My why. So I'm assuming a lot of people joining this webinar are most interested in the social determinants lens on this, because there's tons of the payment reform, value-based payment conversations going on. And that has always been what I've been wanting to do in my life. I didn't know the words for it then. It was social justice. That's my calling card. and couldn't quite figure out how someone changed the world. And I tried lots of different ways. I got into community organizing, really moved me. That was actually my thesis in my public policy program, was why public policy school is bad, because it's not teaching you how to be an effective change agent. But community organizing did. And I randomly fell into community health centers because I saw a job. We were moving to California, applied for one job, and it had homeless and farm worker in the title. And I thought, that's definitely part of social justice. I'm into that. And I found the health centers. And for me, it was like coming home to something that I had no idea about. I'm fortunate, I suppose, enough to not have known about community health centers because we were middle income growing up. And it spoke to me that it was this whole, I mean, it remains, one of the things I love about it is it remains a brilliant policy construct that most Americans don't know about. And we all want them now. We call them like kind of mini Kaisers in California. If anyone knows Kaiser, it's an inclusive system where, and for those who don't know, community health centers deliver medical, behavioral health care, oral health care, optometry, chiropractic. I mean, the whole echelon without a hospital, that is what they are doing. And they do it in the community with people who look and come from that same community. So it's culturally competent. And they've lived through it and they know about the social determinants that impact health. And that was like, that's where I want to be. And immediately realized we're not really making a lot of progress, like institutional racism, food insecurity, homelessness. Why can't we do it? And you start seeing a lot of the threads go back to the payment. So it gets, I've actually never, I can't tell you that I feel like I've really done a lot in social determinants because I've been so focused on how did we get into this rut in healthcare where we are now incentivizing the medical system to have people be sick. That's how we all get paid. The sicker you are, the more money that we're going to get. And there's something so wrong with that. So that's why I've been working on it for so long. And then it's just so hard. It's intellectually fascinating and complicated that's kept me in this game for a long time. But if we can go back, if we can kind of go back to the Jack Geiger roots of food is medicine, that's kind of the gold standard that keeps me going every day. Thanks, Anne.
Thanks, Andy. Now let's hear from Lynn.
Oh, thank you. I agree with everything our other panelists said about why we want to be here. My story is a little more personal. I grew up very, very poor. I was mostly homeless. We moved every 6 months to a new city or a new town. And my mom was, she was disabled, on Medicaid, died of cirrhosis ultimately. And every time we went to a new town, there were 2 institutions that I could count on. That was the local church, whatever one was closest was fine, and the hospital. And the hospital was where I received all my care growing up. So there, we weren't in a community long enough to like establish primary care. So primary care was the hospital. And what I learned was the amount of dignity that they afforded my family was so amazing. It was like that one place we could go where people treated us like human beings. And my favorite Christmas my whole life, as a child, was when I spent in the hospital, and just this outpouring of love and support. And so, I've seen, like, since the Affordable Care Act, hospitals have become the enemy of the people. And I'm not really, and it's like hospitals are not hospitals. And county and community hospitals, rural hospitals are vital, vital institutions, and typically the anchor of where all care for the poor are given, in that community, and they turn no one away and they treat us all well. So I'm just, as I proceeded through my career, I wanted to give back to these people. My whole life was like, I just want to give back to the institutions, the doctors, and the nurses that have made my life possible. And that's why I'm here. For those that are playing at home, I will also tell you that the best opportunity for shared savings is the safety net. Because if you work with these people one-on-one, that's what we did at Caravan. We just, nurses everywhere, just working one-on-one with patients, trying to change how their trajectory of their disease. But once you made a change, they stayed on that track and you monetized them for life. And that's where a lot of the costs are, right? And so there's benefit to society, but there's also benefit to providers that are in this care to pay a lot of attention to the safety net and invest their money there, because that's where they'll get the greatest return. And that's how we ended up saving $500 million for Medicare in rural America. It was just because nobody had ever taken care of those patients that way before.
Thank you, Lynn. And at this point, I'll just say a quick word about myself. Ann Leffler. I'm the principal associate at Apt Associates, and I'm also the co-lead for the Health Resources and Services Administration account. My primary area, as you might have guessed, is with the safety net and ensuring access to high quality healthcare for anyone, regardless of their ability to pay or anything else. And my story, which I'll abbreviate, is very similar to yours, Lynn. We grew up without insurance in Southern Ohio, rural community, dirt road. We didn't have a health center in my community. 10-day hospital stay, very generous community, and really actually started off thinking I'd want to go into medicine, but then I realized that I'm kind of a germ phobe. And so I went more into public health, which has been rewarding because I really dedicated my career to federally qualified health centers as a product of the civil rights movement and social justice. So everything everyone has shared has so resonated with me, and it's probably why I invited you to join this panel and have this conversation among friends. So with that, I'm going to start off with our first question and also invite you to ask each other questions as we go, which is, when you think about value-based payment models today, what would you describe as their current limitations to being able to truly integrate social determinants of health? What are we missing, and what needs to change in order to serve our highest cost, highest need individuals and families? And I'll invite Andy to start, and then if you want to, then from there we can kind of have a conversation.
Yeah, well, so I'll speak at this from the community health center perspective, and we, community health centers receive, so community health centers, for those in the audience who don't know, I think that we're serving 30 million people now across the country. In California, I think it's 1 in 6 Californians are served by a community health center in a state of 40 million. I'm not remembering my numbers anymore, but it's a lot of people. And we primarily serve Medicaid and the uninsured and a little bit of Medicare. Not very many commercial, because Medicaid is the main payer. And there's clinics, but community health centers who serve the safety net, who get grants from HRSA, they have to meet a whole bunch of very tedious, heavy regulations. They have community boards, they have all these good things. They also get a special payment called PPS. It's called the Prospective Payment Model, which on the continuum of payment structures was an enlightened payment model. So, but it's building off of fee-for-service. So this gets me back to fee-for-service. So fee-for-service, right, as we all know, is I go to the doctor does a code, a visit, right? Maybe there were some Band-Aids, there were other things they bill for, all of those things. Health centers, recognizing because of Jack Geiger and the work of thousands of people, it's a much more inclusive experience, and it's more than just the doctor visit. It also is the MA, maybe the dietitian that you see afterwards, maybe it's the transportation that you got to get to the health center because it was really hard to get there. It's the support structure that they provide, the exercise classes at the end. It's an inclusive. So the prospective payment model is an inclusive rate that is encompassing of those things. And you get paid that bundle, that money. It's kind of like a bundled payment in a hospital structure. And no matter what, if you come in with 10 things that are wrong with you and it's an hour, which all the doctors in the community health centers wish they could do, but it's usually 15 minutes. But if it were really expensive, you're still going to get the same amount of money as if it was a 5-minute visit. So that's kind of the model, enlightened at the time, but it is still predicated on fee-for-service. And we're trying to transition ours to an APM, which in FQHC land has regulation to it, an alternative payment methodology, which has to be at least what you would have gotten under PPS. So it's still married to PPS, which is awesome and unawesome at the same time, because it's still sitting on top of a fee-for-service model. So right now, as we're trying to change, we're in just continued discussions with the state. They still want to hold us to a visit-based structure, but allow us flexibility, but keep us tethered. So that in some ways it's this there's a paternalism in fee-for-service, where the payer needs to know exactly what you're doing and the amount of value, and it's all tied to a CPT code, which are these tiny little units. And so we seem to have this inability, despite saying value-based payment, to untether ourselves from a system, because we don't have other ways to value it, but we know the micro units by CPT code. So for me, that one is this insanity that we keep talking about not having fee-for-service and then being regulated by fee-for-service on the other side.
Thanks, Sandy. Seiji, would you, or Dr. Hayashi, would you talk a little bit
Please
about?
help me, Seiji.
Okay. Could you talk a little bit about how that plays out in the clinic, in the patient experience?
Sure. And so, like Andy said, when a patient comes into a community health center, there are many, many different types of services that can be provided to, each patient that comes in the family. But very few people know how, those, the staff and the roles and responsibilities that they have, how does that get incorporated into, a clinical setting? And, and at Mary Center and many, many other clinics, and most clinics, it's through grants, it's through other types of funding. And if you kind of think about how the federal government is structured, and you have a Department of Health and Human Services, you have, HUD, Housing and Urban Development, you have Department of Education, you have, all these different departments that are siloed. Community health centers actually apply for funding from all these different, places in order to make sure that they have the staff to provide social services, housing support, education. For example, at Mary Center, we partner with it used to be a program of Mary Center, and it's now an independent, not-for-profit public charter school. Now we get direct, per pupil funding, from the Department of Education or the school district of DC in order to fund, those educational services. And so it requires a community clinic to really look for funding, to support each of these different lines of work, whether it's housing, education, medical legal partnership. There's so many different things that, patients that come into community health centers needs, and trying to put together the funding to just even hire the staff and create the programs. That's a major challenge. And those were some of the complaints that I had to the managed care plans that were in attendance at this meeting that I was at.
Yeah, that's one of the reasons why I joined Apt Associates, frankly, is because we have a health practice, but we also have experts who have dedicated their careers to HUD or to Department of Labor or to Social Security or to EPA or Department of Education. It's really fun to be able to work with people with such deep expertise with those government agencies. So I'm glad you brought that up, because it can get complex. Lynn, tell us about how this plays out in rural communities.
Well, it's interesting. I may kind of riff off of what Andy was talking about a little bit about the all-inclusive rate, right? And so that's something that FQHCs and rural health clinics share, is they get paid an all-inclusive rate no matter how much they do or how little they do. And I found that to be one of the biggest challenges in working with the safety net is the all-inclusive rate. And Andy, it's funny to me because we're trying to change behavior, right? And in order to change behavior, you have to know what to do, you have to know how to do it, and then you have to measure it constantly. And you've got to be able to measure things that are, process measures and things like that. And so actually CPT codes help us because I can, track all kinds of, wellness visits. I can track mammograms, colonoscopies, things like that, that make it helpful. The fact that in a rural health clinic, the all-inclusive rate also includes the annual wellness visit meant that nobody got the annual wellness visit. Right. And so as I saw, like in fee for service, you get paid really well for an annual wellness visit. Man, you could get them to 50% of their patients in no time, right? But I struggled in rural health clinics and in FQHCs, even though FQHCs get an add-on payment, they're really not geared towards add-ons, right? I mean, and so I'm really curious. Hopefully I'm not answering your question, but I'm really curious, like how do you solve that in the safety net, and how do you deal with the all-inclusive rate, which is really the enemy of getting some of these micro things done, like, eye exams and things like that, diabetic eye exams.
That's interesting because PPS, I like to jokingly, lovingly refer to it as the Holy Grail. Like, it is what I would say made community health centers 30 million people strong. Like, it really worked, but we got to the end of the cliff because now we built ourselves out, but now all we know how to focus on is the visit, because right, salaries are what, 80% of the cost structure, and you have to keep up, and you have to. Someone said it to me recently, because we talk about 15-minute visits, which in your mind, you're like, yeah, 15-minute like phone calls, like not really a big deal. But if you had 22 of them a day, like 22, that struck me for the first time, and I've been in this business for 15 years, and I'm like, oh my God, I never thought about that. 22 discrete, totally random, not related appointments every day that are really complicated for the brain, really emotionally taxing, because people come in with a lot of heavy stuff, and you have to get through 22 of them in a day and then go write it up and follow it up every single day. So in terms of like, how do I solve this person's homelessness, which is the reason for whatever they're coming in for, and the team is all structured towards the doctor to get the doctor through the 22 visits. That's the entire ethos of that channel. So to break it, and I agree with you, it's like everything to me always ends up as like the good and the bad. You have to accept the fee for service CPT codes in order to move away from what we don't want with those unit-based measurements. Like, it's both. And then of course the irony is that health centers are terrible coders. We don't code anything because we don't have to. We get paid no matter what happens. So there's a story in California of a group of health centers getting together to form an ACO, and they lost money because they had never coded their patients to be sick. So then they couldn't prove that they were making them healthier. And there's no reason, this has also been what's so hard, there's no reason when you're doing, everything is on this 22 visits a day, just working through it. And we're like, well, you need to start coding better. I don't have time for it. I don't have time for it. But value-based payment is coming. I don't know when it's coming. I don't have time for it. Like, I can't, right? The machine has to work so hard. So to have anyone thinking or interjecting like creative ideas into your process is really, really, really challenging with what, say, Dr. Hayashi Seiji was saying. And you're trying to work with HUD, and you're trying to work with the Department of Education, and everybody has a different metric and a different process. So, I mean, if anybody, like, it's crazy making when you're trying to address social determinants on the ground through the machine that we have created in healthcare.
That's fascinating, Andy. I agree with you, because like all of our patients our HCC codes are 1, right? I mean, we know we've got the sickest patients, but HCC says differently.
Yeah.
And trying to get providers to code for that, like you say, it just adds more time to the visit. We had to actually set up a separate workforce to do that work. A completely different process, because there's no way that we need to push any more of this onto doctors. We need to give them more time with patients and take all of this administrative crap off of their plate so they can actually practice the art of medicine.
Yeah. I wanted to call out really quick, and I'd love, Seiji, if you would talk about this. I've never heard someone say value-based payment, it's about changing behavior, which I think is a really interesting way of approaching it, that we're trying to change behavior. And I'm just curious, Sethi, from a doctor's perspective and being in the health center, does that resonate with you? Right? Instead of, does it feel better? Does it feel, I'm just curious. You're right. It is about changing behavior.
Yeah. I mean, before I get to the changing behavior piece, one thing I wanted to mention is that this all-inclusive enhanced reimbursement that we get from CMS at the health center level, people think that that should, that enhanced payment should pay for social services, should pay for transportation, should pay for all of this.
Yeah.
But it doesn't, right? Because like 20% of most community health centers, activities are actually uncompensated, period, right?
Yeah.
So free care. And like at Mary Center, which has a $70 million annual budget, 8 million of it goes to uncompensated care, literally free care. And so there's actually no room for adding social workers and behavioralists and others. And so that's why additional funding is necessary. And once again, it's about where is this funding coming from? But you're right about the behavior change. The only problem is that people think about behavior as an individual thing. It's actually an organizational, right? It's an organizational behavior change that is necessary. And we talk about value-based care as value, not volume, right? But it's actually that concept actually comes from the physician's perspective. We don't want to do more, so don't I don't want to get on this treadmill and seeing 22 patients a day, and some many practices see more patients. But then who does the work? And as Lynn said, the nurses, the care coordinators, the navigators, they're the ones who does the work. And it's still, work in terms of the volume. You have to make the calls. You have to engage the patients, and it's actually somebody else doing the work. Yes, organizationally you can shift, the task of many of the non really essential, like clinical decision making. Only doctors can make diagnoses and certain type of treatments and prescribe. Everything else should be sort of pushed towards somebody else. But the health center, the health system isn't created that way, right? And so how do we do that? The other piece is that, like Andy said about, this relentless number of patients. If you look at organizations like Kaiser, right, where they have the payer, the health services, the facilities all wrapped up into one. If you go to a doctor's office in Kaiser, does it look any different? Does it function any different than any other clinic? No, it doesn't, because the doctors are still seeing the patients every 15 minutes, right? Because that clinical care, and the prescribing and the diagnosing and, all that still has to happen. And so I think, it's a misnomer that like healthcare delivery is going to change by changing the behavior of the physicians. It's really the organization, where we put, our emphasis. And it really does have to be prevention services, or else we're never going to bend the curve. And like Andy said, housing, education, employment, food, all those things have to be in place in order for us to bend the cost curve.
Yeah, and I just want to add, sorry, Lynn, really quick, that as much as all of us who get into this because of social justice, most of us only talk about money, which feels so like, oh, like I'm now part of the system. But it's the driver of all the decision making. Before in California, this is our second stint on trying to do an alternative payment model, and the first time we couldn't get it across the line for reasons unnecessary for this conversation. But what I tried to do in the interim was like, okay, well, we'll try to figure it out without the state. Let's try to get a health plan. And there's just the amount of money that health centers, the bolus of money that they get from Medicaid is so big that unless you change that, doesn't matter how many incentives, right? Because maybe listeners are like, well, just incentivize some value, like put some value money on the table. It better be ginormous. I mean, like billions of dollars to change the organizational structure. Right? It has to be the bolus of everything that they receive, or else it doesn't have a return on investment to do what Sage is talking about, organizational behavior change.
And I think that one of the differences between the safety net and fee for service is that that Medicare, and this is shout out to the policymakers. I think you've done an amazing job, and like the world has changed so much in the last 10 years for so many people. But Medicare, for example, they pay for wellness visits and chronic care management. And so we can do incident to billing, and I've got this code and that code, and I'm building an infrastructure in my hospitals based on those fee for service codes. Right. And we need that in the safety net too. So the safety net's like, oh, you get the PPS rate. No, the PPS rate is basically keeping health centers alive, right? And so if you want additional work, you have to do the same thing you did in fee for service. You have to give them extra payments for being in these programs that allows them to put the infrastructure in place, because they can't just do it with what they've got and the doctors just work harder. The doctors are working as hard as they can, and we need to remove the burden from them, which means we need extra funding for extra staff to do this work, because if we have that funding that is tied to certain activities, we will affect change in these populations. We've seen it, right? Andy, I mean, Seiji, we know we can make a difference. We just need the funding to do it. And we're only funding value-based care really in fee-for-service today.
So Lynn, let's imagine that these changes happen. And given that access has expanded so much over the past few years, there are a lot more people who have insurance now than used to, than we were growing up. So what does that mean for for-profit healthcare? And what is their role, and how should policymakers, there are a lot of state agencies and government agencies on this call, how should they be thinking about the role of for-profit healthcare as additional resources are invested to support the shift to value-based payment? And the profit margins are thin now, but the demand has grown so much.
It's a great question. And, I think there's a lot of tension right now because, what philosophically is desired is that the providers are independent. That there's no consolidation, that everybody figures this out on their own, and we're all just going to do better care. And it's really, really hard. It's just not logical, or it's not going to happen. And also, we've learned in our own work that you need scale to do value-based care. You're going to move the needle a couple percent. It was just in health affairs again, right? In order to see a couple percent change, you need 50,000 lives. All right. And that eliminates 80% of the healthcare system. So we have to aggregate people. There has to be conveners. And I know there's like pushback against conveners because they're afraid of consolidation, right? And they're like, oh, you're going to fix prices. But it's like, you can't just let 1,000 flowers bloom and expect this to work. We at Caravan, we had 700,000 patients. If we lost 1%, it was going to cost us $70 million. And we had to take the risk on behalf of all of our providers, because safety net providers cannot take risk. They can take risk every time they get paid, right? They're getting paid so little. And so there is no big piggy bank out there. And so this is driving consolidation. It is driving why is CVS out there buying practices? Why is Amazon buying practices? It's because, we have insurance because providers can't deal with risk on their own. And it's the same in value-based care. If somebody's going to have to write a check, it's going to have to be probably a for-profit company, because I don't know about you, Andy, but like when, on your board, but when I went out to rural boards, 5 years ago and said, okay, we're taking risk now, I had zero. Everybody said no. 100% said no. And we were like, okay, well, if we're going to keep doing this, we're going to have to take the risk. But every year we risked our business going out of business. Right.
That's amazing. I'm still, Lynn, totally. I will, as having worked at the state association, rural is always the head scratcher. Like, what are we going to do about rural? They're losing population. No doctors want to work there. They're geographically dispersed. They, like, the people that are they will also say it's really hard to hire people who are out there, and like the pool that you are hiring from is really limited, and it's not. And yet you built a rural ACO, which is to me, it's absolutely mind-boggling. I've been working on it in California with urban that looks so much more well positioned, and yet rural was able to move. And I'm just curious if you could say a little bit about how you crack that nut that no one else can seem to get open.
You know, I got in my car and drove to hundreds of rural hospitals and sat down with the boards and explained, you know, this is the future, but I promised to take care of them. I promised to protect them. I said, nothing bad will happen to you. I promise. You know, there's no downside. I'm going to bring you, you know, just new processes, and I'm going to bring you income. But again, the only way to do it was to completely protect them from the downside, and then provide the resources nationally, sort of at scale. So we were in 44 states and Guam. Go Guam.
Well, and can you talk a little bit about what you've created in California and why? And just so I'm not sure everyone understands what you have there.
Yeah, well, I think you mean on the payment model, but I want to do so I recently became the CEO of these two nonprofits, which is a consortium, like a policy and advocacy consortium. And then we also have the same replicated board on the network side. And I would say this to all the payers. I knew I've been working with this group, right? My mentor was the former CEO, Ralph Silber. This model in California is pretty unique that we have. It's unique in California, and I'm pretty sure it's really unique in the country, and it's brilliant. And I think every community health center should be doing something like this, where they form a network. So this happened 20 years ago, where the health centers in Alameda County said, you know, if managed care is coming in Medicaid, we should get involved with that, right? And that's a little bit like talking about dancing with the devil. Like, no, like managed care is bad. Like we're social justice. And they did it, and it's brilliant. And the construct, right, is so what we do as a network is we take professional risk with the Medicaid plans in Alameda, and we manage the specialty network. So I have nurses on staff, we have some doctors on staff, we manage all of that, we contract for it. And in theory, and yes, can we continue to be better? Yes, but in theory, and it's working, we take the risk for the specialty care. So we've expanded what we're able to do for our patients. It's not just primary now. We got you in the specialty care network too. We're all inclusive caring for you. We have nurses watching you in the hospital. Once you're in the hospital, we're doing utilization management. And if we do a good job in primary care, we get to keep the returns on that. If we don't spend it all, right? If we manage your specialty, if we manage how you are doing in the hospital, if we get you out faster, like we do better financially. And then that money goes right back into the health centers. So you just reinforce the base. You just keep reinforcing that base. And that's how, you know, to Lynn's point on, you need scale. In managed care, you need scale. Population health requires scale. So now we're trying to take our PPS, which is the fee for service visit-based model, and shift it into a capitation model where there's flexibility. So you can see them 22 times or not. You're now incented not to have them see you. Be as healthy as possible so they don't have to come see the doctor. Get a whole bunch more promotoras out on the street and having conversations and getting more education classes out there. We have these amazing programs on behavioral health pediatric navigators. I mean, these amazing different types of positions to fill the gap, because anybody who's been in the healthcare system is like, well, who do I call? Like this 1-800 number? Like what? Right? And especially if you're low income, you need some help. Like that's a complicated system. You get lost immediately if you don't have the navigators, if you don't have the coordinators, if you don't have all of these people. And that's what I think makes the big difference for Sethi when that person shows up. There's all these people who got you to your follow-up. They got you food. They got you assigned. They got you connected with a housing navigator, right? Like all of these things enable then a much more productive healthcare visit.
We have a question in the chat that I want to raise. It's kind of like in alignment with what you were just saying, Andy, about people who on the ground who can help connect that social determinants of health, those services, when currently there's very little infrastructure that really brings those entities together in a comprehensive way, requires navigation, support, and all of that. So what are your thoughts, especially for our state and federal policymakers on this call? What are your thoughts on the strategy of states looking at 1115 waivers that focus on building that infrastructure among different social service providers, community-based organizations, state agencies, and managed care organizations? What do you think will be most helpful for these 1115 waiver approaches, integrating social determinants of health? What is going to be most helpful for them to be successful?
I'll take a first pass. I'm sure everybody has. So I will say one thing is that FQHCs and 1115 waivers are not friends, but state plan amendments associated with 1115 waivers can be friends with APM. So I'm just, for lawmakers out there, we've looked at it a lot. It's a non-starter for FQHCs, but there's a lot you can do otherwise. And California has this really amazing 1115 waiver called CalAIM, which is it's for anybody in other states where you feel like it's maddening in the Medicaid environment. It had been in California, lots of different initiatives all over the place, different types of measures, crazy making, and always felt like we were against the plans, we were against the consumers, we were all fighting for ourselves in the Medicaid space. CalAIM is in alignment towards, we're all going to follow the same measures. So what the managed care plans are tasked with, or what the community health centers are tasked with, or what the state's working on, hospitals, we're all aligning it. And then they've built in a whole, right now we have all this money for behavioral health expansion, especially in schools and with kids. We're doing a lot more. We have CHWs are now a benefit. They're now an eligible provider in California, not for FQHCs, but for everybody else. Doulas are part of the benefit. So now, like, you can build them into the structure. I will tell you, it's all the right thing to do. We haven't figured out how to make it magical because you are taking disparate functions of the system and then saying, let's get in alignment. And that's not easy. If you haven't spoken to these entities, like CBOs now, community-based organizations can engage in Medicaid, and they're like, I'm sorry, like, how would I do that? Do I have to, like, do I have an MPI? No, like, and we're having to work through those pieces. And I would say it's really, you know, we always talk about Europe as they have they spend all this money in healthcare and all in social services and little in healthcare. They figured it out. Here we spend all this money in healthcare and little in social services. CalAIM is an attempt to kind of weave those things together, but I would say healthcare is going to have the most money. We have a very strong lobby. We are all part of that lobby in healthcare. We are going to defend healthcare. The entrance especially with community health centers and safety net, is that we have already, most of us, because of the grants, we have a lot of relationships with CBOs. We have a way of making that connection work. And I would say we're a really good resource to make connections between other systems, but we still haven't quite figured out how to make that easy, right? Because the government is still going to be the government and has lots of rules, and it has to follow this form, and it has to be at this point in time, and it's always like 50% less than it should be. So it just creates those blocks, but I think we're starting to make progress, and I think people should watch California because so far it's going really well. And I think just because the alignment is there and all of us want to be working towards it, but we have a lot of kinks to work out.
One thing I can't comment on the 1115 waiver, but one thing I want to stress about what Andy just mentioned is that the coordinators of all the different services need to be somebody who is trusted by the patients, right? And that's why it works in a community health center system, or, you know, even a rural hospital where, you know, the community members actually trust that entity. And one of the most eye-opening things that I'm learning, you know, now that I'm in managed care, is that we have dozens of care coordinators and case managers in our plan. Hospitals have dozens and dozens. Community health centers have lots of care coordinators and navigators. But who is able to engage the patient most effectively to connect them to services? And I want it to be the community health center, right? And so that they can get to the clinic, they can get an appointment, they can see the primary care provider and keep them out of the hospital. But there are lots of people who are unattached, as in like, or engaged really peripherally, and they don't feel comfortable in any one setting to develop that relationship. And I think that's one of the big challenges in the U.S. healthcare system, where people actually don't know where they can go, nor do they trust, right? And then let's bring in all the different languages and culture and those issues, and that complicates everything, right? So, but I do think that the coordinator should be an entity like a community health center where they can get most of the care and who know the community and can kind of connect the patients and their families.
Oh, I'd like to plus one on that, Sethi. The remote care coordinator is a waste of time and money, right? And it's confusing for the patient. We felt it was very important that the care coordinator was part of the practice and that was part of the visit. And so we changed our whole visit flow so that it ran through you saw the nurse first, right? And that did that comprehensive look at the patient and address those social determinants of health before you saw the doctor. But in fee for service, you can bill a lot of services under that to pay for that. And we need to fund that in FQHCs and rural health clinics, because that you need that person in the clinic face to face, building a relationship. I have 1,000 stories of patients that said, I started taking my insulin because I didn't want to disappoint my nurse.
And one additional thing that I want to say is that when we talk about care coordination, we have to really discuss families and friends being care coordinators, right? And the amount of energy, time, and money it takes for family members to help the other family member. And I was actually chatting with one of the app staff when she found out that I was talking, and she was talking about long-term care and rehab, for her own family members and how expensive and the benefits run out and what do you do? And then now, they're stuck with the bill as well as, a lot of the support for their family member. And without family members, our healthcare system will collapse, right? And so how do we build that in as well?
Yeah. Great conversation, everyone. This has been a real joy to have you all together in this virtual room. We have a few wrap-up items, and with that, I'm going to turn it back to Miriam to close us out, but just want to say thank you for being here today, and to those of you who've dialed in. Oh, let's go back a slide. I just want to share that our next Social Determinants of Health webinar is going to focus on climate change. We have some excellent climate scientists out of our Boulder, Colorado office. They'll be sharing more perspective on that. And please follow us on all the things listed on the slide. And let's go to the next slide. This is my contact information. If you would like to get in touch with me, please feel free. This is my email address, and hopefully we'll be hearing from you all soon. And thanks again. And with that, we will adjourn. Take care.
Thank you.